Well, hey, everybody. Welcome to episode 5 of the Cutting Edge podcast. It is officially spring. We've hit 80 degrees here in Dallas.
Yeah.
It's the grass is greening up. The trees are green behind us.
Byron Nelson next week.
Byron Nelson next week.
Surely going to rain.
Well, of course it is.
Like it always does.
Yeah, always rains.
But you know what?
New venue.
Craig Ranch is better off handling the rain.
It is.
So we're going to definitely have to talk about that a little bit as a little bit of a preview. So just wanted to welcome everybody to the show. To my left is Tyler Talman, one of the founders and leaders at Carrington Advisors. My co-host represents the average Joe on our show here.
Very average.
So we'll get a great perspective from him as we talk medicine with the guest to my right, Dr. Don Hohman. Dr. Hohman, thanks for joining us today.
Thank you, guys. Glad to be here.
Official practice name,
Texas Joint Institute.
Texas Joint Institute.
Yes, sir.
So and before we get going, I need to give a few mentions to a few folks. So thanks to Texas Assist, Carrington Advisors, Moonshot Marketing Group, and Jen Eaton. Those are all folks that have supported us here to get the Cutting Edge podcast going. You can find those folks on our website, learn a little bit more about them. We ask that you connect with us on social media as well. So we've got a LinkedIn page, the Cutting Edge podcast. You can also find us on Facebook. Follow us on Twitter at TCE Med Pod. So TCE for the Cutting Edge. So at TCE Med Pod on Twitter. Follow us on Instagram at the Cutting Edge Pod, and you can also subscribe to our YouTube channel. So find us everywhere,
Everywhere on social media,
and everywhere you can, and share it with your friends, share it with your colleagues.
Tweet, retweet.
That's right. Just make sure you keep all those terms and platforms straight.
Yeah, it's hard nowadays.
Thankfully, we have my teenage daughter helping us with that.
Let me tell you what we're never going to do. We are never going to TikTok. I can tell you that. I still don't understand this whole TikTok. Can someone explain to me TikToking?
Well, it ain't going to be me.
Yeah, you're talking to the wrong guy.
Yeah.
Thank goodness.
Sorry.
All right, we're out. You can.
Sorry,
we're
not a
now.
Snapchat.
Yeah.
Here.
No. Okay. No Snapchatting.
Yeah.
Thank goodness.
So we're going to stick to the basics: Facebook, LinkedIn, Twitter, Instagram, and YouTube.
Old school.
5. We have 5. The 5 basics.
If you can't find us that way, you just ain't looking.
That's exactly right.
You're not trying.
You're not trying.
And we digress.
So So as we go forward, we're going to spend the next 35 to 45 minutes. Today's topic is a tale of new knees with Dr. Don Hohman, who is an orthopedic surgeon here in DFW and a total joint replacement specialist. Really excited to talk about you with this. We've had a former relationship professionally, working in the orthopedic space, have known each other now for a few years, and we're really going to talk about advancements in knee replacement surgery and really what's going on that front. Let's go ahead and jump right in. If you could tell us a little bit about your background, kind of where you got started with education,
Sure.
Things of that nature, and we'll run from there.
Yeah. So I'm a fellowship trained, board certified orthopedic surgeon, and I specialize in joint replacements of the hip and knee. And I did my specialty training after orthopedic surgery residency. I did that in joint replacement. And so what that means is, that's kind of like my bread and butter. So I do hips and knees. I take care of problematic joint replacements. I do redo joint replacements. But that's not all we do. The majority of people that we see are really people that aren't ready for surgery. They're thinking about surgery, or we're just, educating people about what surgery may or may not do for them. And the vast majority of people that we see, we don't operate on because it's just not the right thing for them at that time. But I did my surgery training in upstate New York. I was really fortunate to train at the State University of New York at Buffalo, and got really excellent hands-on training with some really household names in orthopedics, and I feel really fortunate to have had that experience. And When I finished there, I went and did my fellowship training at the Brigham and Women's Hospital in Boston, and again went to another group of household name surgeons, and just developed some really great, long-standing professional relationships, which have been just wonderful for me in my development and my continued development. And it's been I'm so fortunate. I tell people I'm the luckiest person I know. I've had a lot of really good things happen for me, and so moved to Dallas in 2014, and had to move around with a couple of different jobs for various reasons. And recently, the reason you ask about our new practice name, I've founded my own practice, new practice, as of November of last year with my colleague. We're co-founders of our new venture, and we're off to the races. Everything's coming right along.
That's awesome. So, we've had a few other surgeons join us on past episodes, and they've spoken to how they stay connected with their community that they trained with. Do you have a unique connection that you chatter on a frequent basis with those that you were in fellowship with, or those that you trained under, where you can kind of bounce ideas and concepts and techniques off them?
Oh yeah. So what's unique about our fellowship is that we have a standing yearly meeting, and we usually always get together with fellows from many years previously, and always with the current fellows. And the pandemic has really put the brakes on a lot of these things. And that's one of the things that I used to look forward to the most with attending the meetings yearly, would be getting together with our mentors and talking about cases. Everybody would bring some cases, and we would all talk about, what about this, what about that, the latest and greatest, how would you manage this? But we always, it's a small world, and the surgery world is even smaller, and so everybody's just a phone call away. And it's not uncommon to talk with somebody from previous training, years of experience together previously, somebody who you trust their opinion. You can talk with them about how they might manage a challenging situation. And so we do that kind of thing routinely. I do that with people locally. I do that with people from where I went to residency. I do it with people from where I went to fellowship. And then you meet other surgeons in your community, and you can talk with them too. And so it's very but that's what's nice about orthopedics, is there's more than one way to solve problems, and people are really generally pretty collegial and happy to share their thoughts with you.
Well, that's really cool. We talked a little bit before we got started here, as they were wrapping up another podcast in the studio, but what led you to become an orthopedic surgeon?
Yeah, that's kind of it's a really good question. I when you ask me, like, what else would I do if I didn't do this?
Your response shocked me a little bit, to say the least. I never saw you as the brown truck guy,
Yeah.
A UPS driver.
Yeah.
It was really, really clear to me when I first started. I think the way I always looked at this was, you have to decide if you're a medicine person or you're a surgery person. And so for me, it was automatic. I could not wrap my mind around kind of the long-term solutions sometimes that need to happen with the medical side of management. And so for me, I'm very much I'm here's a problem, let's take care of it. I have a solution for that. And I feel like orthopedics is very much like that, and joint replacement is very much like that. I see people with terrible deformities, horrible arthritic conditions, and have a very, very good solution for those people. And it doesn't take a lot of diagnostic expertise, right? Or it's not some dilemma about what to do for them, how to make them better. You've got a terrible hip, I replace your hip, you're walking in a couple hours and you're home. It's a life-changing experience, and I can do that 5, 6, 8, 10 times a day, and it's really effective.
So almost like there's a sense of instant gratification there that you
I guess you could
see a result
that way.
Quicker,
yeah, exactly, immediately. And what I tell hip replacement patients, when I see people with bad hip arthritis is like torture. These people come in and they're really crippled, and it's terrible for them. And by the time they make it to the office to see you, you can just see it in their face when you meet them. And you tell them, listen, I'm going to take this problem out and away, and I'm going to put, a new hip for you, and you're going to wake up feeling better. And they look at you and they go, there's no way, that's crazy. And every single one of them, every single time, they wake up in the recovery room, you come to check on them, and they go, oh my God, you were right, I feel better already.
Yeah.
So I guess there is some component of,
you tell them, oh no, that's just the drugs.
Yeah. Well, that's a trade secret.
Yeah.
Yeah.
Well, one of the things that I'm curious about is that, just total joint replacements in general have come a long way, but knees and hips in particular, and let's talk about knees specifically, they've just come a long way in the past 15 to 20 years. I remember my grandparents, both my grandfathers had knee replacements when I was young. And it was a brutal surgery. They're in the hospital for a few days. They come home. It's a couple of months, and they're still limping around a little bit. And it took them like 6 months before they were really,
sure,
quote unquote, back to normal. But you could always tell that they had been worked on.
Sure.
So maybe share your thoughts on, what's been the most impactful upgrade or most impactful advancement in the past 15 or 20 years in knee replacements?
Yeah, that's a really great question, and I would tell you that probably the biggest difference maker that we have made surrounding joint replacement as a whole, probably in the last 10 or 15 years, is just being a little bit more mindful about what we call perioperative management. So, for example, it used to be old-fashioned style. Used to be, you'd have a big operation, you'd have a big incision. Nobody really paid much attention to, kind of the delicate process that can go on. This was the genesis of the minimally invasive techniques. You would go, you'd have your operation, you'd get a pain pump after surgery. It's a big operation. You need to have a lot of pain medicine. Yeah. Well, you're laying in your bed after your operation, boom, 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 you're hitting your pain pump. Well, that makes you feel good for a minute. Then you're zonked out. You have these heavy duty narcotics. You're falling asleep. Well, why do you wake up? Because you're in excruciating pain. Boom, boom, boom. You hit your button, and it just creates this vicious cycle. And so, what we've learned about these heavy duty narcotic pain medicines is they create all kinds of other problems. Opioid pandemic and all these other things aside, these things create terrible problems with your GI system. They slow down your breathing. You can't get out of bed if you can't get oxygen to your brain. There's just this vicious cycle that you're creating by giving somebody something like that. And where we've gone away from is all these heavy duty drugs. And so now, the way we look at pain management around surgery is we start treating your pain even before you have pain. So it's routine now. It's customary. Somebody's coming in for a joint replacement. You've got a whole host of pain medicines, a multimodal approach, an anti-inflammatory medicine, a nerve medicine, a centrally acting medicine to block all of those pain receptors even before you have pain. So that, there's
but none of those are opioids. So
correct, exactly. Yeah. And it's not uncommon now that we go through the whole experience and the whole process, and people don't require narcotics. Mm-hmm. So that's how we go through surgery, modifications to the techniques, a lot of these other advancements that allow us to make smaller incisions. We're mindful of doing the operation in such a way that you're not damaging other tissue, that minimizes inflammation, minimizes bleeding after surgery. It's a whole process. It's not just the medicines. It's a whole mindset. And then the other things that are really key is the anesthesiologists that we work with. They're unbelievably skilled with a lot of these nerve blocks. And so, that's another big part of my program is the anesthetic style. Anesthesia is like an art. It's not just knock people down with heavy medicines. They wake up and they're nauseated and they can't get out of bed and they're so sick. And, it's not like that when you've got the right anesthetic program. And so, they do regional anesthesia. They get the nerve blocks in the right spots. People are up. They're really comfortable. They're not in excruciating pain. They're home almost immediately because you've put this whole picture and this whole package together for them, and then they don't need narcotics and they're not sick from the narcotics, and they're able to rehab comfortably because you've got a whole, it's a process, it's a mindset, it's a real paradigm shift really in the world of orthopedics. And that's really been the big difference maker to how we've gotten to this. The expectation now is that you're home pretty soon. after surgery. It's kind of the exception, not the norm for people to stick around now in the hospital for a couple of days.
You find patients fighting that, or do you find that actually we're at a point where patients are saying, I expect to go home because all their friends now, there's enough friends that have gone that direction?
So what I find is that it is a little bit of a mindset for the patient. So some people still, and I think some of this is kind of regional. So, patients in Texas, for example, they like the idea of going to a facility. That's what my mom did. That's what somebody else did. And so they have that mindset. And, if you were other places, like, for example, where I trained in Boston, there's no inpatient rehab. That doesn't even exist. That's
Really?
like only in the most extreme circumstances, so nobody comes in and talks about that. Yet I see people every day who say, well, I'm going to go for surgery. I'm going to be in the hospital for 4 or 5 days, and then I'm going to go to a facility afterwards. So no, that's not the way we do it.
Yeah.
But that's their mindset. Now, in other parts of the country, that those things don't even exist. So you have some regional influences and things that will kind of predispose people to what they think is going to happen. But the home after surgery patient. That is definitely just somebody who can wrap their mind around, I'm gonna be okay. I'm gonna be safe. They got to have the right kind of support to be at home safely. You need a little bit of help. You're gonna have a big operation. You're gonna need somebody to help you get a glass of water, maybe help you get up when you got to go to the bathroom, those kind of things. So it's not like we send people home who aren't safe to be home, but the people who do, who are doing the best, they've kind of got that plan in place beforehand with the right kind of help, and they can wrap their mind around being at home, taking their medicines, and recovering on their own.
I want to shift gears just a smidge because I want to talk a little bit about the business side of this. You were just saying that you branched off here very recently and have a partnership now, and you're in the private practice side, or at least you started your own private practice. At Carrington, I work with a lot of first-generation business owners and entrepreneurs, and I'm curious from a doctor's perspective, because we've had several on the show already. I want to hear what that transition's been like for you, and some surprises maybe you've had, and maybe some of the hurdles you're trying to get over just from a business perspective. Because one of the things, it's fascinating, and I always tell CJ, this is not my industry. And the expectations of a doctor to be so great at their work and to go in and be great in the operating room, and then they're supposed to leave there and they're supposed to be great outside of the operating room, and they're also supposed to be great at business development, they're supposed to be great at all these things. That kind of frightens me as the consumer. I'm like, I only want him to do one thing right, and that's replace my knee correctly. Right. So just walk us through that a little bit as being a business owner and some of the things that you're working on.
You bring up a great point, because what I joke sometimes and tell people is, surgery is the easiest part of my job. Mm-hmm. And I don't know, maybe it's because I've spent so much time, focusing on only that, for so long, and now I've got a lot of these new responsibilities, but there's a lot of things that are really eye-opening when it comes to the harsh realities of making things work, and the taxes that you got to pay, and the burden of insurance.
Taxes.
Right. You're gonna employ somebody, and that costs you too. And so there's a lot of that is eye-opening. And for me now, really with the experience that I have currently and the responsibilities that I have, it's very eye-opening is I guess an understatement, but there's a lot, right? There's a lot of on-the-job learning. There's definitely a lot, and it's not anything that I've had any training for. That's the other thing is, you hear probably every doctor would tell you the same thing. I probably wish I'd gone and done the MD, MBA, or at least had a little bit of exposure to, your spreadsheet analysis and your profit and loss,
financials and
those
bookkeeping,
kind of things, right? Yeah, exactly. Yeah. And there's been a lot of things that I've learned the hard way, and I know that I've been taken advantage of also in some ways by some people that probably look at me as, at the time they saw me as a naive low-hanging fruit to capture and exploit and take advantage of, but we're working past that, working through that. smarter on the other end.
Yeah.
You got to pay for experience,
Baptism
right?
by
and
fire,
education.
Yeah.
So
That's
no matter how you do it.
You said just a minute ago, you go taxes, and I was immediately went to practice.
Yeah. Exactly, right? I mean, it's medicine is just a difficult business, right?
Yeah, oh yeah.
And they but they also call it the practice of medicine for a reason, right? So one of the questions I had for you is, you talked briefly about deformities, and there's a difference between a patient who has a genetic condition that requires surgery versus somebody who messed up their body from wear and tear or trying to be a weekend warrior or whatnot. I mean, when you're treating patients and you're evaluating the need for knee or hip replacements, what's your experience been? Do you see a lot more of the wear and tear? This is self-induced, or is this, it wasn't a matter of if, it was a matter of when
Sure.
you were going to need something like this.
Yeah, and that's what's really nice about a joint replacement practice and my specialty is that there's a lot of variety and a lot of really unique pathologies. While they may all have the same final common pathway, a lot of these people get to that point, in different ways. And so most commonly we see people with a wear and tear run-of-the-mill arthritis. That's your professional football player who broke his knee and ran through it and just took some medicines and kept on playing, destroyed the cartilage, and wound up needing something to be done really early on in life. And we've taken care of a bunch of those people, and they've done really well. Then the other end of the spectrum is you have these patients who maybe there are conditions where maybe you were never born with a hip joint. These things are out there, right? These people are less fortunate than us, and the genetic dice didn't roll in their favor, and so they're stricken with a terrible condition from birth. And so that's the kind of situation where that person might be in that it's a matter of time when we can maybe try to make this better for you and try to make this right. And you can see a wide spectrum of pathology for those kind of patients. And we also see kind of like the middle range of that, where there are certain deformities that maybe any one of us may be born with. We don't know it, and we won't know it around your hip until it starts to hurt you. And and it may be that you're just wearing down your hip early as a young person, and you'll see young people, 40, 50, even 60-year-old people who were born with a condition in their hip. They just didn't realize it, and they thought, I'm just pulling my groin every now and then. Well, that's actually the way your hip is shaped, and it's wearing down. And those are people that they wind up needing their hip replaced early. So you see, a wide spectrum of these things. And, some of the things that are really heartbreaking are some of these patients, very young patients. I've done joint replacements in teenagers. I've done joint replacements in teenagers because they're stricken with these horrible rheumatologic conditions, where your immune system destroys your joints. And, when you have one of these, like a rheumatoid arthritis or psoriatic arthritis or a lupus type situation or something like that, your body will attack your cartilage and it destroys your joints. And those people are they're really difficult to care for. They're high risk patients, but also their options are we do nothing and you wind up in a wheelchair, or we bite the bullet. Maybe get you some new tread on the tire and see how long we can get you. But those are also people that they take a long time to counsel, because if you're doing something, if you're putting a mechanical part in a teenager, you're signing that person up for the rest of their life with that mechanical part, and it's going to be, maybe 20 years, maybe sooner, more surgery, and they're going to live another 100 years.
We love good hospital stories. There's always good hospital stories, and I know, are working all over the place. So you're working in trauma and Plano and all over the place. So you've got to have your most memorable story, or at least a handful of them. So share with our audience a memorable hospital moment, or you go, oh my gosh, this was quite the night. These are the best.
So some of my most memorable patients are people that that have been some of the most difficult, and trauma patients are always challenging, and they're just people that are involved in, sometimes some really horrific things. And, to see those people make it through that experience, and then to see them on the other end, when you met them and you don't even recognize them when you see them, when they're cleaned up and they're walking again, that can be really rewarding. But, there have been a few patients that I've taken care of with some really extreme deformities. And, I'm thinking of one person, for example. It was a really involved operation, and it required a lot of really extensive coordination between, my wife is my anesthesiologist, and we took care of this patient who was a little person. Mm-hmm. And she had a very extreme version of a congenital problem that led to no hips, for example, and this extreme spinal deformity. And she was wheelchair bound when I met her, and she had this horrific, debilitating pain. And also, when you have one of these extreme forms of one of these congenital conditions, you also have major airway concerns. And so I had to employ my wife's expertise to manage the airway. And we were able to safely do that with some techniques that she has special training in. And then we were able to do a hip replacement for this person, and it required a lot of special planning and special implants. And it was a big production, and it took hours to do it, and very high risk, and went off without a hitch, and everything was great. Then we came back a year later and we did the other side. And so this person, who was literally wheelchair bound when I met them, now walks and has their independence. And it's really amazing. And those are things that you reflect on that on the hard days, right? When it's when you feel like you're getting beat down with the medical record process, and you just can't do any more paperwork. Those are the things that I hate it, right? I hate doing that stuff. And so, but you do enough of that stuff, do a few of these things, and it balances out. Right?
That's so great. You mentioned that your wife's an anesthesiologist. Is she your anesthesiologist in all your cases?
Not all of my surgeries, but anytime I can get her, I do it. She's in really high demand, so it's hard for me to pin her down.
How often does she give you one of these for your work? Like...
yeah. You should have talked to me about this before we decided.
That's got to be a tough scenario. I mean,
reconsider.
Leave it at the office, honey. Leave it at the office.
We refer to her as the smart Dr. Hohman.
So one of the questions I had is you see these patients, and we always think of joint replacements or joint conditions with single joints, but we know there's bilateral replacements that occur, right? People go in and have both knees at the same time. So
that's a great point. And actually, as you were asking me that previous question, I felt like I was just rambling with that other story. But this week coming up, we actually have a gentleman who he needs both of his hips replaced at the same time, because he has such extreme deformity, which has progressed so far in both hips that we can't just replace one hip, because he won't be able to stand up with that one hip.
Oh my gosh.
We need to replace both hips in the same setting. And he's another person that he's wheelchair bound. He's really crippled with his hips, but he'll walk the day we do both of these surgeries, and it'll be it'll be just life-changing, and it's like a miracle. It's really really amazing.
So somebody in that scenario, are we talking about a 1 or 2 overnight scenario, and then they're going home and they're off on their way to rehab? I mean, what's the aftercare situation of somebody that has that dramatic of a change in their anatomy?
So you'd be really surprised. What I tell patients. So I specialize in hip through the front, minimally invasive anterior approach hip replacement. And the nice thing about that is that really doesn't require a lot of rehabilitation. I just tell people, you get up and walk around. I mean, that's the rehab. It's not like you've got to go spend 5 or 6 days a week in a rehabilitation process. We don't cut any of your muscles. We put the hip in between your muscles, so everything is still intact. You're just you have, before you had a horribly deformed, you had a square peg and a round hole that wouldn't move. Well, now we've got you something that's going to move, and it doesn't hurt. So now just go ahead and move. And so that, this guy, he'll probably stay in the hospital at least for a day, just so we can make sure everything's okay. It's a lot of stress to go through 2 hip replacements. Yeah. And his deformities are such that it's a little bit more surgery than you might normally have with a routine hip replacement. But he'll be so much better, so much faster. And, if you could just imagine, every normal function of daily life You know, it's just excruciating. You know, you don't realize how much you rely on your hip until you can't move it, right? Or until it hurts you. Getting in.
You got your wife doing anesthesia on that one?
Yeah.
That's awesome.
Yeah, the 18.
So, you know, when you're doing a joint replacement, is it a requirement to do the whole joint? Because we, you know, in knee replacement, there's multiple compartments.
Yeah.
Right? And the average patient doesn't know. I know that from being in the business, but you know, we hear partial knee replacements happening all the time. So maybe dive into that a little bit.
Sure.
How do you assess whether it's a partial replacement, and is that only good for knees, or can you do that with hips?
Sure. So when it comes to knees, you have an inside compartment, you have an outside compartment, and you have a kneecap compartment. And so men, generally, the wear pattern for men is that they usually will preferentially wear down the inside compartment. Females generally will wear down the kneecap compartment. This has to do with the way that the anatomy is shaped, and so women are more likely to wear down their kneecap before they wear down the rest of the knee. And men, you know, kind of look like they grew up on horseback, right, with a little bit of a curve in the inside portion of the knee, and they generally will wear down the inside portion. Usually, the process will progress throughout the knee. So even though you started wearing down the kneecap, then the rest of the knee will continue to deteriorate. And those are people who aren't good candidates for partial knees. But sometimes you'll see people who have only worn down the kneecap. Saw a lady last week. I had done her kneecap replacement on her right knee, and now her left knee's bothering her, and she's worn down her kneecap. Now the rest of the knee looks really very good. So the way I approach that is that it's like when you go to the dentist. If you've got one bad tooth, you don't lose all of your teeth.
Yeah.
You know, you address the one issue, right?
You don't want to be going to that dentist if he's saying, hey, they all got to come out.
Yeah.
So if you have only one worn joint, you know, there are options for just, you know, resurfacing that one worn joint. And so whether that be the inside portion or the outside portion or the kneecap portion in the knee, all of those things, they work really very well in the right people. Now, when it comes to the hip, so an arthritic hip involves, you know, the socket side of the joint as well as the ball side of the joint. And so where partial hip replacement fits in usually is when you have a break in the neck of the femur. And so we know after years of research of following up these patients, and you're an older person with a break in the neck of the femur, if you try to repair that, the blood supply to that ball that travels along that neck has been disrupted. And so that has to come out. You have to have a replacement solution for that. Trying to stabilize it with screws or plates or things like that, it's not going to work. So those are patients that we talk to about partial hip replacements generally, because their socket was healthy. And if you're 90 years old and you have a neck of the femur that's broken, you don't need a full hip replacement. You're going to do just fine with your socket and a partial hip. In younger patients with a break in the neck of the femur, let's say you're 60 years old, 70 years old, you're walking around every day, you're doing everything you want to do, and you have a break in the neck of the femur. You may have a healthy socket, but those are people that we tend to lean towards replacing the whole hip. The reason is that if you take a healthy socket and you put one of these metal shells on it from a partial hip, it'll probably wear out that healthy socket in, say, 10 years or so, and then they're going to need conversion to a full hip. So if I had a healthy, active person with a break in the neck of the femur, and they're in the appropriate age range for that, I talk to those people about a full hip replacement in that setting.
Is that because the materials last? You know, if somebody's 60 years old, and you just mentioned 20 plus years, you know, the materials meant to last 20 to 30 years or longer now.
Yeah. So the one of the big advances in the bearing surfaces of hip replacements is the plastic liners now. There's really good research now out to about 15, 18 years on those that they're showing almost no wear. And so, you know, we don't know how long they're going to last, but right now they're looking really very good. And so if you're 70 years old and you have a 30-year solution that goes into your hip joint, there's a pretty good chance you're not going to need any more surgery.
No kidding.
Terrific.
Well, you know, I read one of the things that prompted me to have you come on the program was I read an article about you being the first orthopedic surgeon in Texas to do a cementless partial knee replacement.
Yeah.
So, man, would love to have you download on that, because that, to me, that just blew me away. Like, I sat back and I went, how is that possible?
Yeah.
So unpack the story, right, about how that came about, and really what's the underlying technology that allows that to be an option. So
the technology around joint replacements is really rapidly progressing. And so I learned of this style implant, and did some research on it, and it's actually some technology that has crossed over from the spine world. And so the idea is that generally these people who wear down only one compartment of the knee, they tend to be younger people. And so the weak link right now in the longevity equation is the interface between the implant and the cement and the bone. Because what gives way, it's not like the implants break, they end up loosening from the cement which we normally use. The cement that we normally use acts like grout, and it just makes a stable foundation. It interdigitates with the bone surface, and the implant sticks to it, and that's what you get up, stand up on, walk around on right away. Well, after millions and millions of cycles, that cement bone interface can loosen up. That's the failure mechanism for some of these things when they loosen up. So the thought process with the uncemented implants is that if we're putting these partial knees into people and they're younger, well, how do we get them a longer solution? So the understanding of the geometry of bone and the things that you can do with the metal, you can make the metal surface the same geometry as the bone surface. So bone thinks that it's bone when it's actually growing into the metal because it has the same geometry. And so these implants have specialized coatings on them that you can wedge them onto the bone, and the bone will then grow into the implant. And so you no longer have that weak link between the cement and the implant. Now you have a biologic interface, right? Because your bone grows directly into that metal. This is the same thing we do with hip replacements. We've been doing this with hip replacements for many, many years. You know, the norm, you know, in the United States is an uncemented hip implant. It's just that the geometry of the femur, you know, you wedge, say, a square peg into a round hole, and it's very stable, and then the bone will grow into the implant. Same with the hip socket. You wedge a socket into the pelvis that's a little bit bigger, and the bone expands and then contracts around it and captures it, and then the bone grows into that. Bone-like stability. So the geometry of the hip facilitates the uncemented fixation. So it took some changes in the process and the implants and the technique to make that possible in the knees. So now not only are there uncemented partial knees, there's only one uncemented partial knee that you can use currently in the United States, but there's also uncemented full knees, full knee replacements. And those are gaining traction also with the same you know, philosophical and technological principles.
Yeah. Are you a big fan?
In the right patient, I am, yeah. So, you know, when I see some patients who are really very young, I talk with them about this. You know, I'm a very strong believer in that. I tell people that I don't tell people they need surgery. People ask me for surgery. I do quality of life surgery for patients. Now, I feel like I can technically do as good a job as anybody. And I tell my patients this, and I say, these are our options. I will answer all of your questions about all of these and explain to you what exists as far as longevity research and what we know about this and this and this. And I help them make a decision about what they think is best for them. We collectively make the decision together. And so, you know, I have experience with all of these things. I feel like I do a great job with whichever one they think is going to be the best thing for them. And that's how we approach it.
It's terrific. It's incredible.
That's pretty strong stuff right there. I mean, you know, we live in a metro area that has, it's one of the highest per capita surgery hit rates in spine and generally in elective surgery in the country. Surgeons here are uber aggressive, right? Dallas is known for that. Texas in general is known for that. So to hear you speak about the fact that you're not ramming surgery down people's throats, that you say, look, here are your options, and you allow the patient to self-select.
Yeah, you know, it's
to
funny.
A great degree. I mean, you're that's so refreshing to hear.
You know, some people don't look at it that way. Honestly, I see people every week who, you know, I spend a lot of time with my patients talking about these things because I truly believe this. You know, it's their body, right? Yeah. And I tell everybody this. I say, once we start down my road, we can't come back. So we need to make sure that you and I and we all understand we're making this decision for the right reasons and what we're going to get out of it. And I won't tell you what to do. And a lot of people get really mad about that. They want to kind of be told what to do by their doctor. And I just, you know, I know it would be easier. Like clinic would be faster and I wouldn't be running behind and you know, the next person wouldn't be mad because I'm 15 minutes late or something like that. But, you know, I don't take this lightly. You know, it's a real it's not without some risk, and it's in some ways it's a life-changing event for them. And I tell people, look, I'm always going to take care of you. I'm not going to turn you away if we have a problem, God forbid, but it's your decision. It's your body part.
Well, and I have a personal story with Dr. Hohman to share with you, Tyler, and with our audience. So I have a sister-in-law who is developmentally disabled. She's in her early 50s, and she's been in a group home for the majority of her life. And January of 2020, I think so. January of 2020, on a Sunday, we get a phone call that she's being taken to the hospital because she had fallen at her group home. And she has intelligent, in terms of intelligence and communication, she's developed to the level of about a 3-year-old. And they diagnosed it as a hip fracture, exactly what he was speaking of, right? Where fractured the head of the femur, and the surgeon wanted to do a nail, what they call an IM nail, and because I'm in the business, I called my mother-in-law and I'm like, hold on, time out. I don't like this. I don't like the sound of this at all, because I don't like the sound of where we're headed with therapy and compliance issues and all that. And I texted him, and it wasn't 5 minutes. And you texted me back and said, get me the films. He looked at the films. He said, get her to Presby Dallas. And he said, I'm going to make the call. We're going to do a full hip replacement on her. He took all the information in, and they had her in the next morning to do a hip replacement on her. And she has done wonderfully. But he took what could have been a disastrous situation with, and look, many orthopedic surgeons are very good at what they do, and they do the best with what they know.
Yeah.
But this is a scenario where a very young, inexperienced orthopedic surgeon had a tough decision to make. And ultimately, experience trumps a lot. And Dr. Hohman was so great communicating with the family. I mean, I remember my mother-in-law coming home from the hospital after the surgery had occurred. He had sat down in the room with them and just explained the whole thing.
Awesome.
And it was awesome. Like you can't ask for anything better, because most of the time orthopedic surgeons are known to be very aloof and have pretty sizable egos.
They're really good technicians.
Great technicians, but bedside manner tends to lack. And it's been so enjoyable being able to talk to you about this whole subject, because not only are you an expert and you have so much knowledge, but man, you're a great dude to be around.
Yeah.
And you're very humble. I mean, for being as knowledgeable as you are and as good as you are at what you do, it's awesome. So, final thoughts, for me, how can people find you?
Much like you have all that social media presence.
Yeah.
Sounds like you're a little more savvy than I am, but yeah. No, we have a lot of those. I'm the only Dr. Hohman on Facebook. We have a lot of our patient stories and things like that on there.
How do you spell your last name?
Hohman.
Okay.
Yeah. First name Donald. And we have our various websites. Our practice website, Texas Joint Institute. And we have a social media presence as well. So a lot of those same things, a lot of that same information, educational information, things like that. We can find all of those.
Is it you answering your Facebook, or is it your handler?
I have a lot of help, but I do get sent the messages that need attention immediately. So if there is something that has to happen, I do get those messages. Yeah.
Awesome. Well, we're gonna take a moment here and pivot, and we're gonna move into the second segment of the show, which Tyler and I we're diehard golfers and golf addicts, self-proclaimed, and we're gonna talk about the upcoming Byron Nelson. So we are.
Hold on.
Don't ask me hard questions. I'm not gonna.
I wanted to shout out to Sam Burns last week. I like Sam. He won the Valspar LSU Tiger. He was 2016-17 first team All-American there. But But cool seeing him break through. Did you watch him at all in the team event the week before, New Orleans? Hitting the ball so good, but
He ain't scared. I know that much.
no, he's not scared. And we're at Quail Hollow this week, and we're already fast forwarded to next week to the Byron Nelson. But go ahead.
Yeah, but you
go
know
ahead.
what? I do have to give a shout out to one of my fellow Wisconsin Badger golf alumni
Okay.
who set a PGA Tour record by competing in the Valspar last week.
6'8",
6'8" Jordan Hahn,
tallest guy
tallest
ever.
player to ever play a PGA Tour event. Who held the record prior to him? You're a tall guy. You should know this.
I don't know.
Phil Blackmar, 6'7".
Phil Blackmar, golly, great
Prior
senior
to
tour.
him, and prior to him, George Archer at 6'6".
Yep. Quick pick for this week. I think Hovland's going to come through. He's a 20-1. So if you're into a gamble, I think it's Victor Hovland's week. He just moved to number 7 in the number 11 in the world golf rankings. Guy hits the ball so good.
When is Zal? I want to know. We got a local kid here, Will Sal Taurus.
He may win the Nelson.
He is
Really?
en fuego. I mean, the kid was 2 years ago, like 2000th in the world. He is now 38th in the world ranking.
Runner up in the Masters.
Runner up in the Masters.
Wow.
And does not have a PGA Tour card.
Yeah.
38th in the world and is not a member of the PGA Tour because the PGA Tour has an old antiquated rule. He's made like, what, $2.5 million or something like that this year?
Yeah, he's looking to be the first player in the history of golf to be on the Ryder Cup team without a PGA Tour card.
Yeah.
No kidding. Wow.
Yeah.
So we're at Craig Ranch, Byron Nelson next week, new venue. What do you think about it out there? You think it's going to be a good spot?
I think they could shoot 30 under.
I think they'll go really low. What do you think about it from a spectator standpoint? You think it's a good place to
I think
be?
it's a great place.
Yeah.
I'm a big fan of it. So my sister and brother-in-law are members out there,
Mm-hmm.
and based on the grandstand setup, it's going to be they're only going to allow 10,000 people a day in this year.
You got tickets?
Yep, Sunday.
You get me some for Thursday?
We'll have to. We're going to have to talk about how many shots you get next time you play.
Oh, goodness gracious.
That'll be a little negotiation.
Yeah, I thought if I put him on the spot on the air, Dr. Hohman, I'd get something done. But
Well, it goes without saying, you got to pull for the Dallas kids, right? I mean, you got Jordan Spieth, you got Will Zalatoris.
my trivia question's around Jordan Spieth today.
Is it
When
really?
he won the John Deere Classic,
Okay.
first PGA Tour event, how old was he?
20.
22.
Close. He was 19.
Was he really?
Actually shocked me too. I thought he had reached 20, but 19 years old when he chipped in to win the John Deere.
Well,
Pretty cool.
it's,
He's on hey, listen,
he's on a
he's
heater.
close to breaking out.
He's on a heater.
He always plays good in town. So,
Yeah.
all right, we got to go.
Yep. No, hey, this has been fun.
Yeah.
Man, we
Thank you. No, I
so
appreciate
appreciate
it.
you joining
Yeah,
us.
it's a lot of fun.
We always try to throw a little something in at the end because it can get pretty serious talking about healthcare and medicine and hard charge and surgery. But
I get you. Yeah. No, I'm glad to be involved, and I'd love to help you in any way I can, and
yeah,
in
well,
any of
hey,
these
and
topics.
let's make sure we give a shout out to THCDS and
got
to
it.
Medical City Healthcare.
I got a lot of people that are helping me do what I do. So it's definitely it's a team effort. It takes a village.
Yep.
Definitely, you got
So
it.
we'll make sure that we share and hashtag and
Oh yeah,
and,
that's
and
great.
link up to those guys because they're a critical part of the success, and they have great teams to take care of folks. So
No
Way
doubt
to go,
about it.
host.
No doubt
Good show.
about
Did great.
that wasn't too
That
bad.
was good.
You're not too bad yourself.
Yeah. See y'all next week.
Yeah. Appreciate y'all. Thanks.